of today's session is ward round teaching during COVID pandemic. The format of the session is half an hour presentation by Dr. Mohammed Tariq and followed by panel discussion and question answer sessions. We have already shared the link for any questions. So if you have any questions during the presentation, just please click the link and send your questions and we will cater those questions in the question answer session. I would like to introduce our presenter, Dr. Mohammed Tariq. Dr. Mohammed Tariq is working at Aga Khan University Hospital, Karachi, Pakistan as an interim associate dean education and interim chair, Department for Educational Development. He's professor of internal medicine and practicing internist. In addition, he served as director postgraduate programs within the Department of Medicine, director internship program at AKU, and was also program director of internal medicine. He completed his 2 years Famer Institute Fellowship from Philadelphia. He was also awarded International Fellowship in Medical Education by Famer, and he completed his Master's in Medical Education from Maastricht University. He was invited as a global faculty for the Famer Institute as a project advisor for Famer Fellows Philadelphia, USA. Over to you, Dr. Tariq. Thank you.
Thank you, Amber, for the nice introduction. Assalamu alaikum, Bismillahir Rahmanir Rahim, and assalamu alaikum, all the participants. Today, I'll be talking about ward rounds learning during COVID pandemic. And my focus of presentation would be to touch upon how learning can take place in ward round, what are the objectives which can be achieved, and what modification can be made during COVID pandemics to enhance learning and to achieve the learning objectives, particularly clerkship objectives. Okay, I have no financial interest, arrangements, or affiliation that would constitute a conflict of interest. Now, as you know, teaching in the clinical environment is a demanding, complex, and often frustrating task. A task which many clinicians assume without adequate preparation or orientation. And one of the key clinical learning environment is the ward round. Ward round form the cornerstone of clinical teaching, where students, residents, faculty all learn from each other. It's a combined effort and a team structure which takes place. And in this team structure, learning at all level takes place. History taking, physical examination, patient communication, clinical reasoning skills, approach towards the patient, management of the patient, diagnostic skills, professionalism are all best learned in ward rounds. Medical knowledge is directly applied to patient care. Whenever students in third year comes to the ward rounds, I think they see what they have learned, they are directly applying to patient care. And trainees begin to be motivated by relevance. They see relevance. And then self-directed learning takes place with a new meaning. With the patients, you identify area and go and learn about those areas and then come back next ward rounds and then discuss. So all self-directed learning is a very much part and parcel of ward round learning. So ward round provides an avenue where clinical teacher can pass down their experience to the learners, teach relevant topics during the ward rounds based on the patient interaction, update learners with current literature based on his or own understanding and his or own specialty, help in application of theoretical knowledge into direct patient care, as we already discussed. So, and most effective means of providing learners the various tasks and roles that they would perform as doctors in future. So what are the tasks? Managing a team, because these students would become faculty, will become team leader. How to manage a team, they learn in ward round. Doctor-patient relationship. Directly, the students and residents are involved in patient care, seeing patients, and how their faculty as a role model sees those patients and manage those patients and talk to those patients and counsel those patients. I think this is so important that students and residents learn during the ward round from their faculty and from each other as well, because some of the senior residents are very good counselors and very good communicators, and then juniors learn from that, and some of the juniors are very good counselors and communicators. The seniors learn from them as well. So a number of things takes place in a multidisciplinary way, and I think a number of learning takes place during the ward rounds. So clinical ward rounds provide context for learning, as you know, And most learning is informal in the ward rounds usually, because physicians or surgeons are doing rounds most of the time, do not teach, and then students learn informally from a number of things going on. Uh, and if it is coupled with some formal teaching, I think that serves the purpose. A significant portion is an informal learning which takes place in the ward rounds. The newcomers see how we do things here without being given any specific objectives. Sometimes without objectives, just go to the rounds, which is wrong. I think ideally there should be clearly defined objectives for each rotations. But I think number of time it happens. And what they do being able to do what X does. They identify their own role models and see what others think. If people are doing bad things, they start doing bad things as well. So I think it's very important to have clearly defined learning objectives for the ward rounds. So now engaging the whole team in learning, you see in one of these rounds, I think there is a senior resident, there is a junior resident, and there are two medical students of final year, and they're all there. This is a pre-COVID situation. In COVID situation, if I do rounds like this, I would be caught. So this is very much pre-COVID, about 7 years back picture. So I think people are very close to each other, and that's how learning takes place. But with COVID situation, I think we need to maintain social distancing. I think I'll come to that in my further slides. And you see here the very important thing, William Osler, what he's doing is palpating, he's inspecting, he is auscultating, and he is contemplating. In the fourth slide, is just what thinking during the ward rounds, discussing after discussion. I think it's thinking what is going on. I think a number of times with complex cases, I think you need to think at the ward rounds. And I think so that is another thing which you learn during the ward rounds. So this was a study we conducted on learners' perspective on medicine ward rounds. 134 trainees, including medical students and residents, almost equal distribution. And what they found that conveying medical knowledge, we asked these questions that how important they are and how much they are covered during the ward rounds. So how important they are, the answer to this is conveying medical knowledge, teaching clinical skills, professional attitude, communication skills, clinical problem solving ability, presentation skills, approach towards the patient, management of patients, medical ethics, counseling, bedside examination, management, and leadership skills, all learned and all need to be learned during the ward round. And every student and resident said, I think out of 5, they it's all more than 4 almost score they got. So I think all these skills can be learned during, but when we ask how many of them are already covered in the ward round, a number of them were not very much covered, like particularly bedside examination. They said management skills and diagnostic skill was the best covered during the ward rounds. And they were very much satisfied with this. And they said that clinical service education balance need to be maintained during the ward rounds. So situation after emergence of COVID, what happened? Ward rounds learning compromised. Why? Because we have to maintain social and physical distancing. There were closure of medical schools, not only in Pakistan, everywhere in the world. And there was work from home procedures. Less number of residents were also there in the wards. Less number of team members in an individual team. Use of PPE. Definitely, you are wearing everything. I think you are not very much close to the patient. You may not be examining patients properly or in detail. Decrease in number of non-COVID patients, because initial surge of COVID pandemic, I think we have seen that non-COVID patient, even acute, we were not seeing many acute MI patient or other condition patients. So I think there was decrease in the number of non-COVID patients, seeing patients with mostly non-touch techniques. A number of faculty were not touching the patients because of the risk, definitely. And I think wherever needed, they were touching, but I think there was always a risk of infection. Bedside teaching and team discussion was also limited. Exposure with quarantine and isolation takes place, and a number of faculty, a number of students, number of residents were going back and forth in isolation and quarantine, and less time spent at the bedside during the ward. So these were all reasons why ward round learning compromised during the COVID-19. And I think you can see here suspended medical schools and clerkship due to COVID-19. I think this is happening worldwide. This is one of the study from US. They say that all the clerkships were stopped because of COVID, and I think they were discussing how this was a challenge, how they can continue with the clerkship. Another study where clinical placement has the cornerstone of medical teaching since the early foundation of the medical profession. COVID-19 pandemic generates unprecedented challenges for the delivery of medical education, particularly in the setting of flatten the curve public health initiatives to curtail transmission. And with this flatten the curve public health initiatives, I think there was less number of students. Again, closure of medical schools was a part of it. And as the number of cases of COVID increases, hospitals limiting medical students' attendance at the ward, clinics, and theaters, representing fundamental shift of medical clinical education from bedside to online format. Definitely, everybody started doing some sort of online teaching, but I think the other of didactic teaching online were relatively easily done, but clinical teaching online is really a challenge. Again, another study perspective highlighting the same closure of things and patients and safety of healthcare workers about regarding this COVID pandemic. This is one of the model which we propose most of the time, that how you conduct ward round, a learner-centered model for bedside teaching in today's clinic, and how academic ward round can take place. This can apply to COVID situation as well, but it's mostly not before COVID, or maybe once we are out of COVID, we can clearly apply this model into it. Now, what is that model? Before rotation or before the rounds, M is before the rounds, I is during a teaching session in the rounds, and plan is after the rounds. What is M? Meet all team members before the once. If suppose I am doing a round on a particular day, I'll go to the wards and I have a whole team with me, including medical students, residents, and all. So I do a meeting with them, get to know each other, and ask senior resident what are the number of patients and where teaching can take place. Set an agenda for the rounds, identify one or two patients where teaching can take place, and then start round. And now this I part is one of the identify patient where I would do a much more teaching, and where I'll follow these I's: introduction of the team agenda and purpose to the patient, then inspection without any interruption, and then encourage students and resident to ask questions. So student or resident would present case in that particular patient, and then after consent from the patient, and then a discussion takes place, and followed by one of teaching opportunities, discussion about the patient care, or learners encourage learner to ask questions, and then or maybe identify a topic and ask the learners, and then identify one of the topic to ask them to read about it and come and discuss the next day. So this is my plan perspective of doing a ward round, but this is mostly without a COVID situation. Now, and again, if you see, planning is before, thinking interactively is during, where you teach, where you listen, where you diagnose patient and diagnose learners, and then afterward there is a reflection. Diagnosing a learner, clinicians, as I always emphasize this slide in most of my presentations, that clinicians differ from clinical teachers differ from who are clinical teachers. Clinical teachers are those who have these academic titles like assistant professor, associate professor, senior instructor, professor, and clinicians are those who are only doing clinics. So there is a difference between clinician and clinical teacher. The work of a clinician is to diagnose a patient with high quality, and work of a clinical teacher is diagnose the patient as well as diagnose the ability of the learner. And in this diagnosing of the ability of the learner, most of the time we forget about this. We just behave as clinicians. I think we need to think about these things. Now, my suggestion for the rounds during COVID situation, the team should be limited in number, but still led by an attending and including a team leader who is a senior resident and medical student. So team would be there like previously, but limited in number. Each patient is assigned to a resident and a medical student. For each patient, there may be an assigned resident and a medical student. So in each patient, there may be two resident and medical student may be assigned. And then round starts in a conference room where team sits with social distancing, limited in number, sits with social distancing, maintaining 3 to 6 meter distance, and there will be a social distancing in a conference room. The round should start in the conference room. After introduction, senior resident provides an overview at the outset to mention what is the criticality of the patient in the team and where teaching takes place. Patient one presented by an assigned resident and medical student, and discussion takes place. So everybody is sitting in a conference room. Patient one is presented combinedly by the medical student and the resident, and history and physical examination presented by medical student, management plan and diagnostic approach presented by the resident, all sitting with social distancing, and a discussion takes place. Then attending consultant stand up and goes with these assigned student and resident to the patient and sees that patient and do some decisions there and come back to the conference room and provide feedback to other members what is going on. And this goes on for each patient. And for each patient, different set of student and one, two or three members go with the attending physician to see those patients. And in addition, there should be a discussion in detail on one learning area in one identified patient, again in the conference room, not in the bedside. In ideal situation where we would be away from COVID, then I think everything can be done at the bedside. But I think in the conference room we can easily do these things. Learning from the patient, what I suggest to students and residents, identify learning points from each patient during the rounds, make your own assessment and plan and discuss with the senior resident. Carefully listen and observe presentation and history and physical exam from other residents and medical students during the rounds as well. And ask clarifying questions from your senior resident and the attending physician all the time. Because if you ask, you would be clarified in your understanding. So the another approach is just want to mention these modeling, how what methods can be included in teaching students and residents. Modeling, the faculty can serve as a role model. Coaching, directly teach the students and residents. Scaffolding, support the students and tailor towards making them more independent. And as they become more competent, you reduces or finally withdraw support. So again, scaffolding, this can all apply in COVID or non-COVID situations. Articulation, ask teacher questions and encourage, ask student questions and encourage them to ask questions as well. Then reflection, always reflect upon what is learned, and then exploration, identify an area to learn about from the literature. And 1 minute preceptor model again can be applied in patient setting. So I'll move on to the virtual learning and virtual board round, which is how these are now included in the curriculum in different parts of the world, and what are some of the experiences which people have shared in literature. I just want to share those here as well. So virtual bedside teaching rounds with patients with COVID-19. So what they have done, that to conduct virtual bedside round, the attending physician affixed an iPad Pro to a computer on wheels using an elastic exercise band and ran the video conferencing application. So there was an iPad during the round, and there was a mobile a trolley with them. And in that iPad, they connected this to a video conferencing application. And the computer was connected to a meeting to share important diagnostic finding. And students were sitting remotely in one of the conference room, or maybe into their own areas, to see and hear the attending physician patient encounter. Students asked patients questions, and patients shared their perspective of COVID pandemic. Institutional policy for infection control was followed. So this was one of the method they used, and I think it can be easily applied in our situation as well. When we want to limit students and residents into our board rounds, we can have iPad or maybe a laptop there on the wheels, and then it can be connected to the conference room, and directly there may be a video conferencing, and a patient encounter can be followed, and you can do that. So that is one thing. Another digital medical education virtual ward round. Another way, the same thing was explained here as well. A vision of use of technology in medical education after COVID pandemic. Now, what they are saying, the COVID pandemic has a major disruption change to medical education across the world. When the pandemic resolves, transformative changes is likely to occur in the way that technology will be used in medical education, especially with the integration of emerging technology. There are significant benefits to this transformative change, but there is important challenges that need to be addressed. Now, if we are using technology, there are significant challenges of using this technology. And if the future and continuing use of technology in medical education is to be effective and have a positive impact on both educators and students across the world. So this can be, now we have been, the number of places have been using these technologies in conducting rounds and number of things. I think these can be continued in future, but I think as the time goes, the challenges with these technologies would also come in, because technology has all the challenges, because it's not a direct one-to-one thing. It's an electronic thing, and I think we need to see what challenges can comes up, and I think we need to fix those as well. Live stream ward rounds, a tool for clinical teaching during the ward round. I like this one very much. This is a live stream teaching strategy that can be applied to all areas of medicine and clinical. Now, what they have explained, that it's a three-phase live stream ward round. In the first stream, what they have done, that a consultant does the round along with the resident. So a consultant and a resident sees a patient, and a single medical student via mobile phone is connected to them. So the interaction of consultant with with the patient and the residents with the patient is seen by the medical student remotely from mobile phone or maybe any device, from remotely from his home or everywhere or anywhere. And then this during this encounter, or maybe not one encounter, during the whole round, the student is asked to observe critically and then makes notes of the patients and patients encounters and everything. So they they observe this during the live stream. And the second part, they, based on those notes, student case presentation phase, student takes notes during the ward rounds, which I've seen previously, where resident present the case, consultant sees the patient, and there is a discussion, management plan, everything is discussed, and students just observe and makes notes. And if there is a clarifying question, student can ask clarifying question as well. The second part, student case presentation phase, student takes notes during the round, as was done in the previous one. Student formulates ward round presentation, and as if they were the junior medical officer. So this is presentation is developed by the student. And the third phase, clinical educator phase, where group of 3 to 40 medical students via video conferencing software are connected. Single student present cases to the group as if physically present in the round. So what the student has observed during the live stream round from the consultant and the resident, the notes, based on the notes, develop presentation and present those encounters to the 40 students. And educator facilitates clinical discussion around the cases. Core skills required for transition to a junior medical students, and student present real clinical outcomes with this presentation. So this is a 3 phases of live stream ward round, in one of the Australian medical school has adopted this. And I think this is a very good way of a stepwise approach towards learning in a virtual rounds. So the another innovations for continuous education, there are another ways we believe that innovative solutions to virtual teaching can facilitate valuable and safe educational experiences. And different, they've explained different educational solutions. Virtual round, new models for caring. Virtual rounds may be refined to involve medical students in remote clinical areas. Students could tune into ward rounds and might benefit from having designated times for asking questions related to the cases presented, as well as following up patients. Now you can see here, this is a screenshot taken during a virtual round. Now here, what is going on? This is an EEG of a patient with a seizure. And you can see in the bottom, there are a number of people are connected, a number of students and faculty and residents are connected remotely from different areas. And there is a virtual round, ward round takes place, where this EEG is discussed after discussing the patient. And I think the investigation can also be projected and discussed in the case of virtual ward rounds. And I think this is one of the examples you can see. The other thing is mixed reality headsets in hospital help protect doctors and reduces need for BP. You can see this is a HoloLens, which is weared by a faculty who is seeing a COVID patient. And there is a camera which is there in this HoloLens, and this is connected to a video conferencing room in another area where students and residents can be sitting and using Microsoft Teams to secure live video feed to computer screen in a nearby room. And you can see mixed reality teaching rounds, where they saw the patient from the clinician's point of view with electronic records superimposed on Microsoft HoloLens headset image. So I think number of modalities which different people are using in the world to make learning happen. Students were able to interact with the clinician remotely, or which facilitated participation and clinical reasoning. So the students' involvement through virtual round rounds could provide an opportunity to reach clerkship learning objectives. If we do not ask the student to do any rounds, because of physical distancing, they cannot do rounds, and if we do not do virtual, I think their objective may not be achieved. The graduation may be delayed, and a number of things can happen. Or may they know, if we do graduation on timely, then their competency may be questionable. So I think in order to reach clerkship objectives can be reached by virtual grad rounds. It has all limitations because real patient feel would not be there. I think that is always a challenge. And I think clinical reasoning skills, history taking, diagnostic approach, management of the patient, all can be learned virtually. But I think, yes, physical examination and touch of the patient would be difficult. Counseling and communication skills can also be learned virtually by directly communicating through mobile phones, or anything, reducing demand for personal protective. So smartphones can also be used, as I already mentioned. I think this is one of the another studies supporting a smartphone. Virtual write-down using smartphones can facilitate staff and another patient. So again, I already emphasized on smartphones can be used in virtually. Um, Distance learning in clinical medical education. Another study, I think, again, this study is focusing more on challenges with technologies. Now, technical and infrastructural resources reported as a major challenge for implementing distance learning. So, understanding technological, financial, institutional, educators, and student barriers are essential for successful implementation of digital learning in medical school. So again, distance learning application or virtual ward round application, I think it has all its challenges, and I think related to student, related to faculty, related to technology, related to a number of things, finances, and a number of things which could be a challenge. I think always those need to be identified and those need to be looked into. These are some of the tips for virtual teaching. COVID use of video conferencing already discussed. Turn on your webcam whenever you are connected in a learning or teaching activity. I think always it's important that learner as well as faculty, I think, turn on their webcam so that they are visible to each other, so that natural feeling of real touch can be there. And then ensure quality of listening experiences, build a sense of community. It's important to limit lecture time. Again, I think if you're doing online things, it should be limited in time. Engage learners often. Ask questions, clarifying questions during your discussion. Use the chat function as well. In addition to that, limit the online session to 60 minutes. Keep your presentation simple. Follow up with learners after the session. So these are some of the tips, not for the virtual ward rounds, but can be virtually for all teaching activities which can take place. So in conclusion, ward rounds form the cornerstone of clinical teaching. Ward rounds learning is compromised with the emergence of COVID-19 pandemic. There is a challenge of continuing medical education, particularly in the setting of flatten the curve initiative to curtail transmission. Clinical teaching can be continued by using various measures, including limiting members in the team and social distancing. 1 minute preceptor and Collins cognitive apprenticeship model can be applied for clinical teaching. COVID-19 pandemic necessitating a remodeling of medical education, and virtual ward rounds and live stream ward rounds introduced along with the clinical distinct along with the distinct challenges with a significant amount of success. But I think how successful they are and what are the limitations of these things with time would tell us. So I think further long-term studies are needed. Maybe we can do it here at AKU. Maybe we can introduce virtual ward rounds in some sort and then see how it goes. Innovative solutions to virtual teaching can facilitate valuable and safe educational experiences. And I think I would end my presentation here. And thank you so much for your listening for this. I hope I was on time. Yeah, I think so. And I think there will be a panel discussion now. Thank you so much.
Okay, thank you, Dr. Tariq. Thank you so much for such a wonderful presentation on ward round teaching during COVID pandemic. Okay, so now we move on to the panel discussion along with question answer sessions. I would like to introduce our panelists. We have invited experts from different specialities, from medicine, from surgery, from obs and gynae, and from pediatrics. So our first panelist is Dr. Sadaf Khan. She is an Associate Dean of Undergraduate Medical Education and Director of Center for Global Surgical Care at AKU. She is currently the program coordinator for the General Surgery Postgraduate Program. We have also invited Dr. Faisal Ismail. He's an associate professor and vice chair of education in the Department of Medicine. He's also the chair of AIR 5 committee in the undergraduate program. Dr. Ismail is a senior fellow of the Higher Education Academy of the UK and a certified healthcare simulator educator. We have invited Dr. Arshaloz Rahman from pediatrics, and she's working at the Aga Khan University Hospital in the Department of Pediatrics and Child Health. And she has completed diploma in health profession education from Aga Khan University. Dr. Alia Aziz. Dr. Alia Aziz, she is working as an associate professor in the Department of Obs and Gynae. She has completed her master's in health professions education from Aga Khan University. She is the director of the fellowship program of gynecological oncology, Department of Obstetrics and Gynecology. So I welcome you all, and now we move on to the panel discussion. We have participants from Dar es Salaam and FMIC as well. So we will take the questions from the participants. The link for the queries and the questions, we have already shared the link in the chat box. So if you have any questions, any queries, please feel free to send your questions via Google form. So we have received few questions and I will address one by one. The first question we received from the participant is, as mostly everyone from the healthcare setting, including doctors and residents, they have received COVID-19 vaccine. So why to carry out these virtual rounds? And why can't we just observe the live patient with the consultant and the senior resident? So over to the panelist. And
Can I respond to this?
Ji, Dr. Tariq.
Yeah, so I think others can also add. I think vaccine, yes, vaccine is given to most of the healthcare workers, and the efficacy of the vaccine, I think it's important. And what I've heard from the infectious disease people and other people, and what I've learned about the vaccine, that yes, it is effective, but still you need to continue with your personal protective measures. Why? Because the number of studies which have been done with the vaccine is to decrease the viral load. You may get the infection, but the severity of its infection may be low, but still you may get the infection despite of getting a vaccine. That is one thing. But still, I think this is a new disease. A number of strains are also coming up, and these are the vaccines still in the new phases, and we haven't seen long-term effect of these vaccines yet. So I think at least for a significant number of period, I think you need to continue with all the precautionary measures to have a protection from this. But as time goes, we would be more clearer about this. Maybe anybody else could add on this.
May I add, Dr. Tariq, a little bit to it as well? It's not only about being vaccinated and self-protection, it's about being into a carrier state, even though you may have received the vaccine, and transmitting it to your patients and the people around you, number one. And number two, in pediatrics, we know that the disease is never severe. In fact, we have silent carrier children around us. So I guess this new norm is going to stay at least for quite some time. And the teaching definitely has to change its shape, like we just have discussed. So protecting others is also an important thing. Only the healthcare providers are getting vaccine right now in our setting.
Thank you, Dr. Arshaloz. Any further comment from other panelists? Okay, so let's move on to the other question we received from the participants. Can we teach ethics and professionalism to attend what patient virtually? So can we teach ethics and professionalism? G.
So can I say, ethics is a way of thinking, right? Ethics is really a way of thinking. It's not something that you learn as a skill on a patient. And that can be done in any setting. So I don't think that precludes things. Professionalism, there's so many aspects of professionalism: showing up on time to your virtual session, having your camera on, being attentive, participating, being respectful to the other participants. These are all components of professionalism. And in fact, I think it adds another twist and another added layer to the professionalism that to aspects of professionalism, but that we all must learn and become cognizant with as we move forward in this new environment. So those are two things. I think the only thing that you have difficulty learning are actually skills where you use your hands. Everything else, communication, medical knowledge, everything I think can be learned online. The only thing that suffers are clinical hands-on skills. That's it.
Thank you, Dr. Sadaf. Any other comment from the panelists? No. Okay, so the third question is, why don't we arrange for students to make videos on the simulators in the simulation lab, and having faculty members provide feedback on clinical skills during this pandemic? Yes, over to you, panel.
That can be done. I think that is one of the another way of teaching and learning. Yes, on simulators it can be also be done. But I think here the focus was to ward rounds. So that's why simulators was not discussed. But I think, yes, that is another modality. Simulators can be used, and I think faculty can take sessions on simulators online virtually.
Yeah, I'll just chime in there to say that I think they should certainly be used. It is, and the reason why I wanted to speak on this was also because this is partly, this is of great interest to me. And I think this is a highly underutilized source of curriculum delivery and instruction. I totally agree with you. Not only can the videos be made, but also sessions can be arranged on simulators. And here I'm not even talking about high fidelity, very expensive stuff. I'm talking about even simulated patients. I'm talking of patient banks that all of us can have in our universities. Using these for the psychomotor aspect of training, as Dr. Sadaf said, where hand skills are utilized, and even the affective component of training. So certainly they can be used. Simulators can be used in a wide variety of ways. And most definitely, I think it is the future, and we should be looking to use more and more of it.
Okay, thank you, Dr. Faisal. Any further comment from other panelists? Okay, so let's move on to the next. What challenges are you facing to conduct ward rounds during this COVID pandemic? As you are from different departments, so what challenges are you facing?
May I, Amber, start with the youngest ones in hand? Once COVID came in, so in that, what we really first stage was that getting revamping our structure of rounds was very important, and making less contact of the residents. So we divided them into small teams and distributed them into different areas. And like Dr. Tariq has mentioned in some of the models, the consultant would go from one area to another, but the residents would be fixed in that area, a small number of residents. And a senior resident would be as a lead person, just having all of them, in one place, so that the consultant or the faculty doesn't have problems. So with that, at least we managed very organized rounds and patient care in the first few months of COVID, till we got into teaching that we could go online for the didactic part and for the case-based presentation. We dedicated a day in our department where we discuss all the difficult cases, 3 of them in one session, and we call it patient care meetings. So that was linked to the rounds, and then those patients passed on a larger forum on Zoom or Microsoft Teams, whatever was available at that time. So we have format blended kind of a learning, where our cases and our mortality meetings, everything has gone on Zoom, and our rounds are small group-based rounds. And still we are continuing in the same pattern. One thing I would like to add that observed learning has to change to reflective learning also in this setting. So getting your students and your residents to reflect on what they have learned would need a session at end of each round every day. So that is one thing which we lacked before, but now I think we need to introduce that as well.
Okay, thank you. So any further comment from other panelists?
Amba, can I say something?
Dr. Alia.
All right. So in OBGYN, we also face similar sort of problems like Dr. Shilus has just narrated. The challenges we faced were that the students, the undergraduate students, were not allowed to enter into the special care units. So the rounds will start, and then we'll see one patient probably on the ward, and then as we say, okay, now we are going to special care, the students have to wait outside because they are not supposed to go inside because of the SOPs by the undergraduate guidance by the university. So what the students used to feel left out because they said, oh, we have, what we'll do. Secondly, they were not allowed, initially they were not allowed to enter into the operating room. They were feeling frustrated because they said, oh, we are interested. We came into this rotation because we thought we'll be going to OR, and now we can't go into the OR. So these are the two problems we faced, but gradually they were allowed in OR. And the special care thing we sorted out by saying that, okay, we will go in, like the consultant and the resident will go in. And when we used to come out, we used to give them a narration about how the patient is doing, so that in probably 24 to 48 hours when the patient comes out, they don't feel left out of what happened with the patient. So they were well versed with what was happening with the patient inside the special care. So these were a couple of challenges we faced, and we tackled them this way.
Okay, thank you, Dr. Alia. Any further comment from other panelists and presenters?
Yeah, can I just say that I agree with both the challenges that have been mentioned. However, both of them I feel can really be resolved if we try to adopt a good virtual a table virtual round. Now we say table because the idea comes from the fact that everybody sits around a table, but that doesn't necessarily need to be. I was on service a few weeks ago where I actually started around sitting here in my office because you know that 4 teams can't begin the same round at the same time in a ward. I mean, there is only one table for them to sit around. So I think, but this needs to be a faculty driven process where the faculty needs to involve every team member, whether they're UGME or PGME. And then I think if you involve everybody in the round, which would mean that you start off virtually, discuss every patient, involve the student as well as the teacher, then the point which Dr. Alia was speaking about, that they feel neglected or bored, doesn't happen because they do feel part of a team. But it's really it's an intensive process. It takes effort, but I think it can be done. And I think if the faculty make sure that they want to do it, then I think it flows down from there.
So
Can I?
Yeah, Ji.
Go ahead.
Dr. Sadaf. Dr. Sadaf, you are on mute. Dr. Tariq, would you like to?
Dr. Sadaf कुछ कह रही थी ना?
Dr. Sadaf, you are on mute.
So, okay, I was saying Dr. Tariq tell them now that so what I wanted to, I agree with what everybody said and what Dr. Faisal just said, that it has to be faculty driven. And then in comes the next challenge, because we as faculty all know that sometimes there are many, many competing demands on our time and attention. As you see here, I am sitting in the operating room because, I had to be here, whereas I'm supposed to be on this panel. And the same thing happens in the morning when you're looking at patients. And as you all know, there are days when there are just few patients on the service and everybody can do a brilliant table round and there can be a lot of teaching. And there are other times when there are 25 people to do all morning and then your clinic starting at 2. And in those cases, things become irregular. And because these fluctuating needs on everybody's time occur, at least I feel that it is difficult to set up a system, because if you did the same thing every day, then everybody gets used to it. But if you have to change things on a day-to-day basis, it becomes very difficult, and the adoption and the uptake of these practices becomes very erratic. And that's a huge challenge that we have. You know, there are multiple people now, as Dr. Tariq has described, there have been multiple ways described, and a lot of them are intuitive. It's not like there's a lot of rocket science, they're intuitive things. But adoption in different services on a different day in the same service varies a whole lot. And what stresses me is that this is how it's going to be for a few years. And our teaching, because most of, at least for our institution, the majority of the teaching is experiential. Yeah, I worry about it. And I'm sure a lot of the faculty worry about it as well.
Thank you. Ji, Dr. Tariq.
Just actually the same point Dr. Alia and Dr. Faisal emphasized, and then Dr. Sadaf, regarding patients on special care. And these patients, students are not allowed to go inside, and a team of residents are also not allowed. Maybe one or two residents can go inside. So, and a number of patients with the typical critical findings or patients with findings are there in the special care where significant learning takes place. And I think if they are not, they are outside and sitting most of the time outside, students, I think they miss out on all these clinical processes and discussions and everything. So what I did when I, usually what I do in my rounds, that whenever we do special care rounds in the conference room with social distancing, I ask resident to present the case in front of the team. And I think there is a whole discussion about the team, which I discussed in one of my slides as well, that we discuss in detail the patient. And then I go to the special care with one or two of the residents who are involved and go there, see the patient, and come back to the special to the conference room, and we'll provide feedback to the team. And then next patient is discussed. So one by one, we discuss these patients so that objectives, and the students liked very much this approach, so that they were involved in some sort of a discussion, not directly patient care, but some sort of some significant discussion of these patients with findings. So I think this can be done. It is faculty driven, and I think, yes, I agree with Dr. Sadaf that there are competing demands. We have to do clinic, we have to do this, we have to do that. I think number of meetings, number of things which are going on at the same time. So it's not easy to manage all these things at the same time. But I think whoever wants to try to do something, I think there are ways in which you can manage things wherever you want. With some,
I wanted to add something else. Sorry, I didn't mean to cut you off, but one more thing is the way we can't have students in special care. Similarly, it is becoming more and more difficult. In fact, students were not allowed to go into the ER anymore. So that's another big area where students were able to see the patient when they presented. And that, I think, was critical for many disciplines, because a lot of especially when you're working in a tertiary care center, when people come into the emergency room, they are at the peak of whatever clinical problem they have. A lot of the management that we expect an undifferentiated doctor to be able to go through is done in the emergency room. And that is missed. For the surgical specialties, often the patient will go straight from the emergency room to the operating room. And by the time the student then sees it, the crisis is done and over. There's no physical examination left. The appendix is out, the ectopic is out, everything's done. And it's just by hearsay that they learn, yeah, there was right lower quadrant pain. For medical specialties, the patient goes from there, shortness of breath, pleural effusion, dyspneic, everything, gets his tap, this and that, ends up in the special care unit, spends the next 2 days there being diuresed and whatnot. By the time comes out, nothing left. Ready to go home, regular diet, advance, have a bowel movement, discharge. So these are really significant issues. And, I've been trying to see if we can get them back to the emergency room, but every time I walk down to the emergency room, there's a new set of curtains and a new thing, ye ab COVID ho gaya. So I don't know how we're going to get around this. It is a
To
challenge.
start thinking about virtual, some sort of a virtual element included in the rounds, so that maybe a small group of us sit together and plan for some sort of a virtual guidelines.
Okay.
Yes,
Thank
may I add, definitely this is a big problem, having continuity of patient care starting from ER to the time they exit out to the hospital. Even in non-COVID days, it was a big problem that, students were not able to follow those patients from one end to the other. So I guess now with all seniors sitting together, maybe starting from ER, having a virtual kind of experience of these patients if they can't go in. So the patient goes out through virtual connection, and then having a continuity of care plan for teaching would be a very good idea.
Okay, thank you. Any further comment? Okay, we will take the last question. All these maneuvers for engaging students, they take time, and most of the clinicians, they do not wish to put in additional effort or time. So any comment on this? Yes. Any comment from the panelist?
Well,
Dr. Talia?
I would say that before we say that the faculty don't wish to put in the time, I think we should be a little kinder with that. There are many very, very good faculty who are excellent teachers. And I think wherever possible, whenever possible, people are here and teachers because that's what they love to do, because there's really, I don't want to get into a whole discussion of why one works here. But at the core of it, I like to believe it's people who would like to make a difference by how they train the next generation of doctors and specialists. I think we have to be cognizant of the demands on this faculty. And I think as a group, we need to create multiple, we need to identify and disseminate and train faculty in multiple modes of online teaching, so that it's just like a tool in your toolbox. Everybody needs to have multiple tools that they can use depending on the situation, the time, the setting, and maybe because it's so new for everything. And we have to keep in mind that we can't underestimate the amount of anxiety this pandemic has created amongst all of us. Everyone has been touched by it in some way or the other. Some people have actually had to deal with infection amongst themselves and amongst loved ones. The amount of quarantines and isolations, each of us has had probably an average of 3. And that time while you're sitting and waiting and hoping that you didn't infect your elderly parent, that's a whole other thing. So we have to keep that in mind and give everyone leeway. And I am hopeful that with the advent of the vaccine, and again, time will only tell what kind of protection it offers, but at least hopefully it will give us some sort of mental relief, and we'll be able to move forward and go from here. So that's just my 2 bits. Let's not be harsh. It's not, I don't think anybody's trying to shirk their commitment, but that's just my 2 bits. Thank you.
Okay, thank you. So any other comment from the panelist and from the presenter? Any further comment?
Just one quick comment that in COVID, we are talking about everything. The frame of mind, the mental stress, the fear, the contracting the disease, and everything was in the beginning really bad. And most of us were literally terrified by it. So were the students and the trainees and the trainers. So we have to at least understand that frame of mind. It's not that no one wants to teach or give time. It was just the frame of mind everybody was in. So I guess now with time, things will get better, and we'll learn the new methods also. So hopefully things will be very different in the coming this year, hopefully.
Okay, thank you, Dr. Ashutosh. Any further comment? No. Okay, so we conclude this session, and I would like to thank our panelists who took time out from their busy schedule and gave their expert opinion. Thank you so much, Dr. Sadaf, Dr. Faisal, Dr. Alia, Dr. Arshalosh, and Dr. Mohammad Tariq for giving such a wonderful presentation. Thank you so much.
Thank you very much. Thank you. Thank
Thank you,
you.
everybody, for attending.
Thank
Thank
you.
you.
Thank you.
Thank you. Hafiz.